I am Dr. Vivek Gupta, working in Apollo Hospital, New Delhi. This is 3rd of July, and we have done a very important case, evaluation of case of coronary artery disease, angina, and also history of syncope. Patient had a fall one day back. Myself, Dr. Vivek Gupta, along with Mr. Basant and technician, who is a very important technician because they always help us in all the problems, and our nursing team, which are not there. So this is an important case. He's a 57-year-old male who had a syncope, fall, and he actually hurt himself, and there was a major bleeding. At the same time, he also complained of heaviness in the chest, and the heaviness in the chest was good enough to diagnose angina. He was referred to us from another hospital and for the further evaluation. We did coronary angiography. Show here. Slowly. And angiography did not show any major blockage. Next view. But of course there was sluggish flow in the LAD, especially you can notice the sluggish flow in the LAD, and this could have been the cause of the chest pain or heaviness, and this is a left dominant system. The right coronary artery, next. So you can very well see the sluggish flow in the coronary arteries, which can lead to rest angina, and this does not require any angioplasty or stenting. You can notice the right coronary artery is non-dominant, and it has got a tight stenosis in the proximal segment. This is important evaluation. Sometimes you have to really do angioplasty, but I would say when we further evaluated, does not have any right PDA, and therefore we did not go for angioplasty, and we decided not to do it. In the same time, whenever you have patient of syncope, you should always evaluate the carotid arteries. You can always do the Doppler artery, but I always feel that direct catheter angiography of the carotid is still a better system as compared to DSA. So we checked out on the left system, there was no blockage, and at the same time the right system was absolutely, left and right both were normal, and there is no blockage in the internal carotid artery. Come back to me. So now we are left with further evaluation, whether what should we do. I thought that this patient had notice that we had a prolonged PR interval. PR interval was about 220, and therefore we thought that we should further do electrophysiological study at the same time. So this is evaluation of the syncope. I was glad to tell all the audience, especially the young doctors, that whenever you are doing an evaluation of a syncope and angina, we have done with the angiography and followed this. You can see the catheter here. We have done a catheter which is we have two venous port, venous line in the groin. One is the atrial catheter, another is a quadripolar, which is going to the his.
One is in the H and other is HRA.
Okay, so one is the HRA, another is this. This is what we have to evaluate, is to find out whether there is a conduction blockage or not. We have to work out and see AH interval and HV interval, and you can show the pictures of the catheters. You come back here. So this is for the quadripolar electrode for the HV for the his bundle, and next is we have the HRA high right atrial catheter, which is only two polar or quadripolar?
Quadripolar.
Both quadripolar. And now we have done pause. So with the help of our technical team, we have measured the AH interval, which is 119, and HV interval is 46. Another place which is showing 54. The upper limit of the HV interval is about 55, and for AH interval is about 120, 130. So when there is a prolongation, if it was more than 80 HV interval or something like 110, we would have done. We also did the pace. We also did the pacing to 110 and 140, and did not find any major Venke back or any blockage or AV conduction delay. So this is about, once again I repeat, AH interval and HV interval are within normal limit. To summarize this patient had a coronary artery disease, angina, which was very classical of angina, having chest pain, associated with the patient of syncope, which was there. One day he fell down and he hurt himself. That means it was actually classical syncope. So in that evaluation, we have to do coronary angiography. We have to check carotid angiography because the catheter is already there, patient already on the catheter table. And then, of course, if everything is normal, you should always check the AH and HV interval to see if there is any electrophysiological blockages which can lead or which may require a pacemaker, permanent pacemaker. In this case, we have found that AH intervals and HV intervals both were normal, within normal limit. And therefore, although we discovered one first degree PR interval was prolonged in the normal ECG, I would say that this patient does not qualify for any permanent pacemaker implantation at the moment. This patient had a non-dominant right coronary artery which has a tight stenosis, which should be kept in the medical treatment. So to summarize, this evaluation of syncope has to be very important. We have to do it very well, finalize everything in the cath lab. In the interest of the patient, one should always check the electrophysiological study which has been done in these cases. Myself, Dr. Vivek Gupta from Apollo Hospital, along with Mr. Basant, who is a very important technician, and Mr. Jogi, who is the nursing staff doing the recording. Thank you for watching this video from Apollo Hospital, 3rd of July, 2018.